Everybody's seeing the slides?
Yep.
All right. All right, so quick case of a patient that's been in and out of a couple of our hospitals here. So I'll try to keep this to the time limit here, but it's gonna be tough. So there's a 23-year-old female with a history of anxiety, depression, and adjustment disorder only, who had just discovered she was pregnant about 14 weeks just prior to presentation. Had COVID, as you'll see, a couple months earlier at the end of 2021. So her first presentation was January of 22, when she developed numbness and paresthesias in her hands, and then progressed up her arms and eventually into her legs. And eventually this led to bilateral leg weakness and difficulty standing. And during that period, she'd had a couple presentations, but also had a lot of vague complaints that weren't, that didn't help people figure out what was going on. When she finally presented with a leg weakness, she had some effort limitation on exam, but was mildly weak in the legs, worse distally than proximally, and had some diminished vibration and proprioception sensation, but had intact reflexes throughout, noted to be 2+. And there was a lot of concern for some functional overlay in her reporting. There we go. She did undergo MRI, brain CT spine at that time, which were normal. Basic labs were normal. And she was planned to have follow-up outpatient to see how things went, but didn't present to any of those appointments. She came back a couple weeks later, now the 20th of January, this time to regional with a fall and that resulted in an ankle fracture. She had the same neurologic complaints, largely unchanged despite the 2-week difference. And neurology was consulted again for ongoing weakness. And at some point, a few days into that admission, the internal medicine team said they couldn't elicit reflexes. The neurology team, however, did note that they could elicit reflexes. They were diminished, but they were present. She had diminished sensation of light touch but had intact temperature and proprioception. So if anything, maybe a little bit improved from the last exam. Again, labs were obtained that were all pretty normal. AIDP or GBS were felt to be unlikely based on her exam because she still had the reflexes. She did not get an LP at that time. And it was recommended she get an outpatient EMG if she had persistent symptoms. But that admission became prolonged, and she continued to actually worsen during that time and then started complaining of significant back pain. So another couple weeks later, now February 11th, she described pain with passive movements and tenderness in all of her muscles, and her lower extremities became dramatically weaker with essentially 0 of 5 power at hip flexion and 2 to 3 of 5 distally to that, along with diminished sensation of most modalities. But again, her reflexes remained 2+ throughout. So at that time, we were able to get an inpatient EMG done at regional, and cut to the chase here. She had a kind of sensory motor length dependent mixed appearing EMG that were suggestive of predominantly demyelinating physiology. And it was felt that it was most consistent with AIDP or Guillain-Barré syndrome. So at that time, she was treated with IVIG for 5 days and ended up spending several weeks in acute rehab, but did make a marked improvement over that period of time. She eventually had follow-up outpatient with our group, with our neuromuscular group, excuse me, in May, and was noted to have full strength except at the ankles and just a little bit of mild sensory deficit remaining. And at that time, her diagnosis remained GBS post-COVID. She came back almost exactly a year later, now January 4th of 23, with recurrence of a lot of these symptoms. She had largely entirely resolved, she reported, but again in January, decreased sensation, paresthesias in her limbs, along with generalized pain and some other complaints, but was also febrile, tachycardic, and again, COVID positive on that presentation. Her exam was pretty similar to her prior, with reduced sensation to multiple modalities and mild lower extremity and upper extremity weakness. And again, her reflexes were still present. This time we decided to get an LP before making any decisions. Her cell counts were all normal, but her protein was mildly elevated at 69. And remember, this was a whole year after her prior GBS. So at that point, we decided to shoot first and ask questions later, and treated her with IVIG again, given how significant her lower extremity weakness had gotten the first time around. And she objectively worsened for the first few days, but by day 4 of treatment began having sensory improvement.
Girl.
So at that time, there was a lot of question whether this was recurrent GBS, which would be uncommon, CIDP, or just recrudescence of her prior symptoms. But it was really not clear at that time what the answer is there. So I think the overall takeaways, and she has some more follow-up coming, so maybe we'll learn more, is COVID is still very much out there, and there's a lot of neurologic complications from COVID, which those of us in the hospitals are seeing on a daily basis. So don't rule out anything. And then be careful making assumptions. So initially, some of the effort limitation on her exam, led to concern that this was all functional, but we don't want to rule out real disease because of some effort limitations. And then I think the other big one here is that classical features are not always classic or not always present. And she had maintained her DTRs the entire time, more or less. So it's not, and there are significant reported cases of GBS with maintained or even hyperreflexia. So we need to keep those things in mind and keep an open mind when making our differentials. And that's what I got. And I think I kept to the 5.
Yeah, Matt, that was great. Thank you so much. We're trying to do a patch here. Let's zoom.
And then should be in this one. So wherever you put that in there, go back.
Burn out. Here it is. All right, we'll just play it like this. This is today's CME code, and thanks for Matt with the technical assist here. So this month is Multiple Sclerosis Awareness Month and Brain Injury Month. Oh, sorry. Well, it's still Multiple Sclerosis and Brain Injury Month. Whether I share it or not. Let's get rid of you folks. Go away. How do I make this bigger?
Right, step down a little bit, over, up, right there. Oops.
Luckily, there are no applicants watching today. We're allowed to mess up on our own. All right, this is the best we can do. With this one? Okay, there we go. Takes a village. Our all-star this week is Dr. Tanzia McQueen, who was nominated by Swaroop and Melissa Friedman for her prompt care of a stroke patient. So congratulations. This is Women's History Month. We'll put together a slide of women in neuroscience. Thanks for that. In this month, 1995, Augusta Marie Desjardins Klumpke authored the influential paper on the paralysis of the brachial plexus. Brenda Milner, who is the mother and father of neuropsychology, was a pioneer of the study of the human frontal lobes. I believe she's still at work in their mid-90s at the Montreal Neurologic Institute. She was the person who studied HM. And Cecile Voigt Munier is elected to the German Academy of Sciences after developing maps of the human brain and basal ganglia. And I didn't know, went on to found the first Max Planck Institute for Brain Research. Jennifer Lavelle was the person who described the use of horseradish peroxidase as a marker of neuronal axons. Alexa Canaday, in 1981, the first Black female neurosurgeon. The great Rita Levi-Montalcini won the Nobel Prize in '86 for nerve growth factor. And Marion Diamond retires at the age of 87 in 2014, was an incredibly famous neuropathologist. So for all the faculty, everyone should have received a DHIP contract. If you didn't, email Megan Phillips. If you have questions, email Megan Phillips. If not, sign and return. They need to be signed within 30 days per the agreement of the PDC. You will be unemployed if you come July 1 if you don't return them. You'll have some explaining to do too. Get to know your APPs. Candace Mooney has joined the headache team at Maureen Road. She formerly worked at Raleigh Neurology and is from ECU. Well, welcome, Candace. Again, the AAN meeting in April in Boston. We're going to have a reunion there, so all are welcome. It's still US News and World Report voting season. I encourage everyone to go on to Doximity and vote for your favorite departments. Those rankings that I keep saying are very important for us to continue getting great residents and fellows. On the research roundup, Chris and Elijah, as well as Kristen Veal and Suma, were authors of an article on long-term steroid use for neurosarcoidosis. And Matt Scaglione was part of an article that looked at dictyostelium, the slime mold's resistance to polyglutamine aggregation. It's very important work. On the sad news, I walked out to my car and saw it this morning. It's back. Any of you new to North Carolina are wondering what that yellow stuff is? It's going to look like snow. It's going to be so thick soon and we'll all be miserable. And it lasts about 2 months. It's really unfortunate because it's one of the beautiful times of the year down here, and people who are allergic like me are basically confined to indoors. Again, this is today's CME code. There's Matt. And here's Matt. So our speaker today is Dr. Matt Luedke. Matt's had a very important influence on my 9 years here. I met Matt probably within my first week of coming here, and he's just been a remarkable member of the department. He graduated from Baylor, did his residency here, and did a clinical neurophysiology fellowship at Duke, and he's one of the EEG faculty as well, epilepsy faculty, as well as the division director. Matt's now an associate professor. Is that news? Okay, not yet, but soon, hopefully. I don't go to the promotion committee meetings anymore. I used to get too passionate at them, and but hopefully soon. And today's lecture Matt's going to give is "It Came in a Pill: An Exploration of Exercise and Epilepsy." And you know, in dementia clinic, we tell all our patients to exercise, and they all say, "Yes, Dr. O'Brien, I am going to exercise." It's the same thing. You ask them if they're exercising and they say, "Yes, I exercise every day," and their spouses, you haven't exercised in a year. If there was an exercise pill, it would be as popular as Ozempic. Even if it was a shot, I'd take an exercise pill and an overweight shot right at the same time. Because exercise is miraculous. And it's often wondered, I've often assumed that when you exercise, the things that are good for you come from your muscle. But the data now suggests they might come from your liver, that when you exercise, your liver activates too and releases its goodies into the bloodstream. And the only way to get them is to exercise. And I wonder if you take Ozempic, you'll get less of those or more of those. You might get more. I have no idea. All right, so we're going to turn, exercise is just such an important thing, and people just won't do it. They won't do it. They'll never do it. That's why we need it in a pill, Matt. All right, thank you.
Folks, it's a privilege to be here. I have a lot of fond memories of this room and a lot of fond memories of grand rounds that I've admittedly slept through after call, or maybe the dreams during those, but I hope no one feels like they need to sleep through this. I will at least make it an adequate rounds. So I'm going to start off with disclosures, none of which is particularly relevant to this, but just for the sake of completion, I wanted to do this. So I'm going to start off with the question, why would a neurohospitalist care about exercise? And why would a neurohospitalist care about exercise in particular in epilepsy? But I could say the reasonable thing, and that is I am also an epileptologist and the subject interests me. But I came to the subject actually through a couple of projects that evolved in 2018, 2019. I've long held that the hospital is, in particular, the emergency department, is the canary in the coal mine for your health system. Functional health systems that address particular issues don't see those issues popping up in the emergency room. And when people do pop up, it's the first time someone's told me my voice is soft. That's good. I like that. When they do pop up in the emergency room, that tells us that something's going on, right? That people are falling through the cracks. And so in 2019, I started a QI project that unfortunately died in the throes of early COVID in 2020. But it was looking at emergency room visits from our Clinic 1L patients. And so this is a table we put together of our Clinic 1L patients who in that calendar year both presented to Duke 1L, but also after presenting to Duke 1L presented to the emergency room. As you can see, there are a lot of emergency room patients, right? There are a lot of emergency room visits that our patients generate. RES, by the way, is resident clinic, strong work. No, it just goes to show you that it's a complicated patient population that our residents have to deal with. Stroke likewise has a really challenging population. Not all of these were neurological encounters. A lot of these were encounters for other reasons. We wanted to drill down on clinical neurophysiology because after resident clinic and stroke, it was the highest volumes of people coming through the emergency room. When we drilled down on this population, it was over 2,000 patients generating 500 plus visits. And of those, 500 of those patients generated a quarter basically of those visits. 200 of those patients generated 10% of those visits. This is your classic Pareto phenomena. The small portion of the patients generate the bulk of the encounters. And the top 10 users, 0.4% of the patients generated 5%. So 0.5% generated 5% of the ER visits. One patient actually generated 61 ER visits. And when you drill down in these visits, the interesting thing is the bulk of them weren't actually for seizures. A lot of them were things like pain admissions, whether it be headache pain or other somatic pain, mental health issues, falls, things like that. So in this situation, the seizure patients, the fact that they had seizures, the fact that they saw us in this clinic weren't so much the cause of the visits themselves, but it was a marker of case complexity. It was a marker of people who were suffering multiple different other problems in addition to their seizures, which, as we'll get to in a second, if you know anything about patients with epilepsy, that's actually not an uncommon phenomenon. In fact, it's sort of par for the course for people with epilepsy. In the meanwhile, I was working on a project at the Durham VA with their evidence synthesis program where they do meta-analyses on subjects. And this introduced me to the concept of self-management. So self-management is a system of basically education for patients on how to deal with their disease at home. It's actually a mainstay of chronic disease, and it's part of the standard medical home models for a lot of disease states, most particularly hypertension and diabetes. In fact, you can't be certified as a medical home if you don't have a formalized self-management program. And this was not something I'd really encountered in my neurology training. So we did this project on it. It was a 2019 meta-analysis and systematic review. And it required really good quality randomized studies. Unfortunately, there weren't a ton of them. But as we were looking at these studies, what we found is that when you break down the kind of self-management strategies that are used in epilepsy, they break down into two broad categories. You have educational self-management strategies. It makes sense, it's self-management, but these are more didactic. They're oriented around training people to identify their symptoms, working on medication adherence, working on coping and problem-solving skills, symptom monitoring. Some might say basic life skills, but these are basic life skills in the context of their disease state. So it's more specific than that. The other broad category was psychosocial or therapeutic interventions. These were essentially CBT-derived, cognitive behavioral therapy-derived interventions that also worked on coping skills, but a lot of this was self-actuation, mood modification, stress modification. And the programs broke down into these two broad categories, but I looked and I thought something was missing. Well, why did I think something was missing? Well, It was also at around this time that I had a significant lifestyle change. If you looked at the picture of me when I was sitting for the photo that they used for my introductory photo, that was in 2015, and it was about 40 pounds more than I am right now. I had forgotten some of the things I knew when I was a kid, and that is, gosh darn it, it's fun to move. Your body enjoys moving. Objects in motion remain in motion, and I was not very much in motion around 2019. And so I was going through a few lifestyle choices, and I came to a sort of a realization that a lot of the issues that had been stressing me out and a lot of my quality of life issues at that time were improving with exercise. Which led me to ask the question, what if exercise were a pill? So I Googled that a couple months ago. It generated almost 200 unique hits. People are clearly interested in this idea. I'm, for the interest of full disclosure, not going to talk about how I'm inventing a pill. If I were inventing a pill for exercise, I would be in an island that I owned somewhere in the Caribbean sipping Mai Tais. But we are going to talk about why exercise is a multimodal intervention to address quality of life issues in a self-management context. So exercise as a medical intervention actually has an ancient history. So if you look at medical history in India, at around 600 BCE, Sushruta was actually the first person to, on paper, prescribe someone to work out, to exercise for a specific health benefit. In general, sort of vague health, health is improved with exercise, you should probably do more of it, sort of assertions can be seen as early in writing as 1000 BCE. And as you can imagine right now, just open up any online venture for talking about health and healthcare, and people will mention exercise. Does it work? So that's what we're going to discuss. What I can't do is provide a comprehensive general discussion of fitness. That would require days. There are entire collegiate and postgraduate classes on the subject. I'm not going to do that. Plus, it was distract us from what we're really here to talk about, is how does this impact our patients with epilepsy, and potentially consider how it can impact our other patients who have other neurological conditions. What we'll do is I'll offer some relevant studies, reviews, and meta-analyses on the impacts of exercise. And I'm going to do this with a particular strategy. I'm going to start off with general exercise literature, because it's a broad and very healthy literature. There's a lot of data behind it, big studies, lots of them. And then I'm going to do a step further. I'm going to take that and look and see how it's been applied to epilepsy in general, because I think when we look at general literature and then try and apply it to a subpopulation, we better have evidence that that subpopulation sticks, that it really actually does continue to have that effect. Then we're going to tie these into particular quality of life challenges for people with epilepsy, the same sort of things that bring them into our emergency room, which is why I care about this as a hospitalist. And then we'll offer some thoughts about exercise at bedside. So what are these impacts of interest that we're going to discuss? Well, we're going to discuss anxiety and depression, weight management, bone health, cognitive health, and cardiac health. I would note that these don't just apply to epilepsy. In fact, if you look at just about any subspecialty in neurology, you can find patients who struggle with each and every one of these, or at least most of these. And so this should have, again, hopefully an opportunity to be a bit of a springboard to look at those subspecialties as well, if you're ever interested in doing that. So let's start with mental health and epilepsy. Depending on the series you look at, almost 50% of people with epilepsy have a axis 1 disorder, a mood disorder of some kind. There's also abundant clinical evidence to show that people with epilepsy have increased suicide rates. So we're talking about very high rates of anxiety, very high rates of depression. They've also done studies to compare that to disability matched patients. So if you look at people and their lifestyle and quality of life limitations in the setting of epilepsy versus things like diabetes or things like that, people with epilepsy have a disproportionately higher rate of anxiety, depression than a disability matched peers. Weight gain. So in one sizable study of patients with epilepsy, 50% of adults with epilepsy were overweight and 30% are obese. This is a little bit of a dated study since everyone in the United States has gotten heavier. I'm assuming that this will trend through, but this was at the time disproportionate compared to the general population. Bone health. Unfortunately, a lot of the medicines we use in epilepsy are poison to bones. They cause osteopenia. Interestingly enough, I might add, there's a little evidence that the bone fragility in people with epilepsy may be disproportionate to the level of osteopenia. There may be an issue of bone quality too. That's a little bit harder to tease out. That's seen in our patients with epilepsy, particularly those on enzyme-inducing drugs, particularly the old school drugs like phenobarbital, phenytoin, and carbamazepine. People with epilepsy are also at marked risk for fractures, even more potentially for hip fractures than the general population, not just because of the osteopenia, but because people with seizures fall, right? They can have seizures and they can fall. They can be quite injurious, and the general injury rates of people with epilepsy are higher than the general population too. Cognitive health. Children with epilepsy are at significantly higher rates of risk for ADHD. Adults with epilepsy are also at increased risk of dementia. And I would add that people with dementia are at an increased risk of epilepsy. And then finally, cardiac health. The population of people with epilepsy in general is a little bit less healthy. As we talked about before, there's more obesity, and obesity naturally dovetails into cardiovascular disease. There's also increased rates of tobacco use in this population, increased risk of sugar consumption, and not directly related to diabetes, but can be related to poor glucose control in people who have diabetes, who have epilepsy. Also, this is a neat field that's just sort of being discussed in the past, say, 5 to 10 years, and that is the idea of the epileptic heart. People with epilepsy are at higher rates of coronary artery disease and cardiac arrest than the general population, probably disproportionate to their increased rates of other cardiac risk factors. There also seems to be evidence for seizure frequency and seizure severity and cardiac injury, myocardial fibrosis. The thought is that it may be successive catecholaminergic dumps that happen when you have tonic-clonic seizures that lead to myocardial injury. This may, in part, be related to the risk for SUDEP, although there's not a clear delineation there or a clear union there. But this idea of the epileptic heart, the idea of cardiac health in patients with epilepsy is relatively new, young, and an open field, and I think it's of particular interest. So these are the things that we're going to be looking at. Does exercise help them? Let's start off with mental health. So there was a sizable 2017 meta-analysis on the impact of exercise on patients with anxiety and stress-related disorders. And lo and behold, there was actually a pretty decent impact on it across the studies. Not huge, but commensurate to long-term outcomes with things like SSRIs. And this is symptoms of anxiety reduction. This is, again, comparable to SSRIs in the long term, and this is with something that's essentially free. Depression, a 2016 meta-analysis, again, a pretty large meta-analysis, showed an impact on people with depression as well when it comes to exercise. Now, when we get into the exercise literature, it's important to note that exercise is a heterogeneous intervention. Not all exercise programs are the same. When they're talking about these, they tend to be heavily laden towards cardiac fitness, so running, biking is a staple intervention because it's easily controlled and measurable. Treadmill interventions are staples, but there's also some cross-training and lifting involved in these, but these programs are predominantly cardiovascular. Let's talk about weight. I think it's worth quoting Dr. Rozier. The best exercise for losing weight is the push away from the table. There's no doubt that diet is the major mover when it comes to weight loss, but exercise is an adjunctive therapy. This was a large 2008 meta-analysis that showed that there was a small but consistent impact of weight loss in patients who exercised in addition to standard dietary measures. Interestingly as well, the dropout rate was similar between the diet alone and the exercise and diet program. So it didn't seem to make people less adherent. So it potentially is an intervention that can accompany good dietary counseling and standard dietary weight loss programs. Bone health. Bone health is a fascinating body of literature. There's a lot of discussion about how exercise may impact bone mineral density, but the impact isn't huge. It seems to be better for weight-bearing exercises than for things like running. But again, it's not a huge impact. But what does seem to be interesting is that aside from bone mineral density, exercise has a significant impact on safety and fracture prevention. In a recent meta-analysis of 20 studies, 23,000 people, big meta-analysis, it showed that exercise programs reduced rates of trauma, both low-level trauma, major osteoporotic fractures, and it was more consistent for people who engaged in supervised exercise, so people who had a trainer that walked over with them through their exercise program, than people who did unsupervised training. So even beyond any notable benefit in bone mineral density, the simple fact that you're exercising, you're moving your body, engaging in strength and agility training improves your rates of fracture prevention because it reduces your rates of falls and stabilizes you when you do fall. Cognition seems to improve with exercise. Again, a decent sized meta-analysis, another recent one, 2020. There's a small but significant effect of long-term exercise on healthy individuals. Interestingly as well, there are some smaller meta-analyses, particularly in the pediatric population, that shows that there's a benefit for exercise in things like ADHD and impulsivity. I have a loved one with ADHD, and I note that since we've gotten them into oodles of exercise programs, they are doing markedly better with their impulse control. And also in the elderly, global function and activities in daily living are associated with improved cognition in that population. So even if they don't have a direct exercise intervention, if they have increased rates of activity in that population, they have better cognitive traits. So it doesn't even need to be a formalized exercise program, just increased activity in general can help improve cognition in vulnerable populations. We'll end this section with a discussion of cardiac health. There's nothing super novel about the idea that exercise improves cardiovascular fitness, but I thought that this was a fascinating study. It's older, it's a little dated, but it's huge. It's based off of the Surgeon General's report on cardiac health and fitness. Basically, the relationship is linear. For each 1 percentile increase from the first to the 99th, sorry about the 100th there, percentile in patients with who exercise, there is a commensurate small but consistent escalation in the reduction of relative risk for people for cardiovascular disease and stroke. So again, linear, right? For every percentile you increase from the population of increased physical activity, you are going to decrease commensurately your risk of cardiovascular disease and stroke. Now, that's exercise. Fitness is a little bit different. It's linear after the 30th percentile. So at the 30th percentile, there's a massive drop-off and health declines markedly. Your increased rate of cardiovascular disease and stroke below the 30th percentile just precipitously drops off. Once you hit the 30th percentile, there is again a stable linear increase in relative risk reduction for your cardiovascular fitness as measured by your VO2 max, a rate of your peak oxygen consumption. Now, some of VO2 max is genetic, so this is a little bit of a messy picture, but the reality is the fitter you are, not just how much you exercise, but the fitter you are, the better your heart health is. So for the general population, it's hard to argue that exercise isn't good for you. You can imagine if it helps with depression, anxiety, cognition, attention, bone health, weight, cardiovascular fitness. If you put it in a pill, it would be a blockbuster drug. Again, if Duke came up with that, it would have an endowment bigger than Harvard, right? It would be a massive, massive healthcare intervention. What about the population of people with epilepsy? First off, the literature in epilepsy is a little bit smaller, a little bit more niche, and the studies are smaller and heterogeneous. So it's going to be a little bit difficult to piece through this, but we will, if you bear with me. But I also think it's important to look at the population of people with epilepsy before we make generalizations stick to them because they are actually, unfortunately, a less fit population when it comes to fitness. This was an interesting study that came out in 2019. The population of people with epilepsy have a markedly lower VO2 max compared to the general population. And what we're talking about here is again, a VO2 max of 31. That's low. A reasonably fit person my age, in their early 40s, should have a VO2 max in the high 30s, low 40s. So that's a pretty low VO2 max population. So it's going to be important to see if this works, right? If you have a particularly unfit population, is there going to be a commensurate response to exercise? And then finally, there's been in the world of epilepsy an unfortunate history of advising our patients not to exercise because of a fear that exercise may cause seizures, provoke seizures, put them at risk for injury during fitness activities. There's no evidence base for that. I looked at literature. There's just zero evidence to support that there's any major risk of exercise-induced epilepsies. There are rare, and I mean very rare, less than 1% of the population, exercise-triggered seizures, but that's as rare as hen's teeth. So there have been some studies in mental health and exercise in epilepsy. So what we found is that structured exercise programs show a benefit on neurocognitive and psychobehavioral function in children with epilepsy. Several studies demonstrated that regular exercise, again, not an exercise program per se, but regular exercise activities, things like playing tennis, going out, walking, jogging, doing things like that, but nothing formal, can actually improve quality of life overall and reduce stressors and anxiety in patients with epilepsy. So it doesn't even, again, need to be a formal exercise program. It can just be a lifestyle fitness activity. Weight management, it seems to actually be a little bit more of a robust effect on people with epilepsy than it does in the general population. In a randomized 2020 study of 110 patients, again, small studies, but not bad for a niche weight loss study. People with epilepsy who exercised demonstrated significantly increased rates of weight loss compared to people who did not. And this was independent of which seizure medicines they took. This is important, right? Because epilepsy medications are notorious for causing weight gain. A lot of our mainstays, Depakote, more recently, drugs like perampanel, are notorious for increasing people's weight. And it's a major quality of life reducer. And again, it puts them at cardiovascular risks. The fact that there seems to be a robust response to exercise in this population, regardless of medication, is an important finding. Bone health. There's not much in the way of research on bone health in epilepsy, in particular when it comes to its impact or its vulnerability to exercise. That said, there seems to be some improvement if you do actual education for weight loss, or sorry, for bone health and fitness in this population. Again, it was sort of a trial, but there does seem to be an improvement in balance, fall risk, and knowledge. Again, I don't think that there's going to be a robust osteopenic reversal in these patients. I don't think their bones are going to get stronger, but there at least seems to be some evidence that they may get less likely to fall with fitness programs. Exercise, epilepsy, and cognitive health. Again, both leisure-related sports and targeted exercises improve cognition. There was a small, again, 21-person study, very small, that showed that there was an increase in MoCA scores, verbal fluency and executive function, in the exercise group. And this, the intervention group was a 10, the control group was 11 patients. So again, small, but there was an improvement. Cardiac health is a little bit of a void. There's not any direct research on cardiac health, fitness, and epilepsy. Again, I think this is something that you could probably generalize, but this is, again, a population that does have a depressed VO2 max at baseline. And there's some suggestion that some of the medicines we use in this population, like Depakote, can have mitochondrial effects that may limit the benefit of exercise. So this is an open area for research. That said, I do think probably the research for coronary artery disease prevention is generalizable. This was the most interesting part. There actually is a little bit of data, just the barest hint, that exercise can impact seizure frequency. There's some animal data looking at electrical activity in the brain and neurohormonal interactions that say that there may be an anti-epileptic or neuroprotective effect of exercise. There is evidence of a decrease in epileptiform activity in EEG in animals that exercise in at least one study. So there's small human studies, again, another publication on that same small 21 person study that suggested that there is an effect on seizure frequency. Again, it's hard to make hay out of a 21 person study, but in the 10 person experimental group, 7 patients had seizures in the wash-in period versus 1 in the study period with no effect in the control group. The control group had stable seizures. So take it for what it's worth. It's a small study, but it certainly didn't increase the risk of seizures in that population. My favorite study in this section was a study out of Sweden. It looked at Swedish skiers compared to age-matched controls. And in this 20-year cohort study of almost 200,000 Swedish skiers, say that several times really fast, Swedish skiers, there was a 40 to 50% decrease in the rates of epilepsy in the population that skied versus not skied acquired over a lifetime. So I think this is largely because the biggest adult cardiovascular risk factor for the development of epilepsy is stroke, and these patients probably had better cardiac fitness. But it is interesting that it can actually be an anti-epileptic thing to exercise. And again, there's no strong evidence to suggest a systematic negative effect. There are only rare reflex epilepsies. Where are gaps in the research? Again, cardiovascular disease, exercise, and epilepsy. There's just a big hole in the literature. Again, with the interest in the epileptic heart that's been brewing up in research in the past 5 to 10 years, I suspect that there's opportunity to study that population and study the subject. Next, again, I came at this because I became interested in self-management. And there's still to this day not really any interest in the self-management literature in adding exercise as a major component of self-management programs and strategies. We here at Duke, thanks to Dr. Stewart over here in the third row, are bringing hopscotch, a well-validated self-management program to Duke to help our patients. And I think it's something that we've needed, and I'm thrilled that it's going to be here. But again, there's really no program in hopscotch for encouraging exercise and fitness. So I think going forward, looking at ways to engage patients in self-management through fitness is going to be important. Another thing, the patient population with epilepsy is slanted towards a population with increased rates of healthcare disparities. It's associated with low socioeconomic status. It's associated with blue collar work, which tends to be a little bit more dangerous, things like construction. And so access to exercise and fitness platforms can be more difficult for people who are in disparate conditions. And it's not just as simple as, well, throw on a pair of shorts and throw on some workout shoes and go run. If you live in neighborhoods that are in low socioeconomic status, some of them are a little bit more dangerous. It might not be the safest place to exercise. You might not have well-paved streets. You may not have access to good crosswalks and running trails and greenways. So healthcare disparities are really important to consider in the population of people with epilepsy, because that's going to be enriched compared to the general population. Also, people with epilepsy oftentimes can't drive. So it's not as simple as going to the workout studio down the street, right? You actually can't get access that easily. Adaptive exercise in epilepsy is another void in the literature. People use treadmills, people use exercise bikes in these studies, but no one actually talks about the safety of that. Are there methods of exercise, cardiovascular and weight-bearing exercise, that are safer in people with epilepsy? You can sort of think through the process, right? It's probably not the wisest thing to do bench press when you're actively vulnerable to generalized tonic-clonic seizures, and treadmills might turn you into a missile, but there's not really any clear documentation in the literature for recommended strategies for various forms fitness in this population. Also, there's a large population of people with epilepsy who have physical impairments and intellectual impairments. And getting them involved in exercise is an exercise in adaptive health too. I think one of the neat things that I've seen in my patient population is I have a few patients who come from very athletic families, and they've gotten their children chariots and things like that if they have trouble walking, if they have spastic paraparesis or quadriparesis, to at least get them out and participating as a passive engager in exercise and sporting events. And they really seem to enjoy that. And then finally, another thing that I didn't see any of is exercise and functional disorders. Whenever we're dealing with patients with epilepsy, functional disorders are an ever-present specter. The rate of functional seizures is about 1 in 1,000 patients. Epilepsy is 1 in 100, so only an order of magnitude difference. It's much more frequent than we give it credit for. We certainly see that in our emergency department and in our EMU, but this is something that I think really would potentially benefit because there's no pharmacological intervention for functional disorders. I'm going to take one brief moment. What about the people who are already active fitness enthusiasts, particularly people who participate in sports? I know this was something I wasn't taught in my fellowship, and I think it's actually really important information for people who counsel folks who have epilepsy who are athletes. In a 2016 task force on sports and epilepsy from the ILAE, the International League Against Epilepsy. I still think that that sounds like the most boring superhero organization in the world, but here we are. The sports were categorized into 3 groups. One was low risk, things like bowling, baseball, golf, running, basically things that you do essentially in sequence or solo, and things that don't have risk for impacts or falls. Group 2 was moderate risk, things that you do by and large individually or in sequence, but at the same time do have some potential risk in the setting of a seizure. So things like cycling sports, projectile sports like archery and skeet, diving and swimming and downhill sports, so skiing. And then finally, high risk sports, basically sports where not only the person is at risk, but bystanders are at risk. So motor sports, sorry, Dr. Ehrlich, sorry, Dr. Skeen, diving and scuba. The general recommendations are there should be really no restriction on group 1 sports. So if you have a cross-country runner and they have a seizure, fantastic, let them go and run cross-country. If you play baseball, fantastic, let them go play baseball. Just make sure they wear a good helmet when they're at bat. Group 2, period of about 12 months was the suggestion in the ILAE. I'm a little bit more generous with my patients if they establish 6 months of seizure freedom, and I'm going to be signing paper that says that they can get into a car traveling 70 miles an hour down the highway. Why can't they swim, right? I think it's a little absurd to say that they can't if I'm trusting them with a 7,000-pound projectile. But group 3 sports are no-goes, right? They are discouraged from participating in those sports thereafter just because of the increased risk, not just to themselves, but to their bystanders. I would also note that from a fitness and health perspective, group 1 and group 2 sports generally have the highest yield for health improvements in fitness. So I don't think we're losing anything by these. So in conclusion, people with epilepsy are often less active than the general population and may have unfortunately been advised by well-meaning doctors that they should exercise less. They should exercise just as much as anyone else, potentially more. Exercise can benefit people with epilepsy and can directly impact a number of the common comorbidities and complications of epilepsy and its treatment. And again, mental health issues, falls, depression, anxiety, these are the things that bring people in epilepsy into the hospital, into the emergency room, not just seizures. Exercise and sports are generally safe in epilepsy. And we should encourage, again, our patients to be active. And when people are already active, we should get them back on the field and we should get them back onto the streets, running, playing as fast as we possibly can and do it safely. And again, there are numerous questions that remain to be asked in this world and numerous answers that we can seek. And so if you're interested in the subject, there's just a free-for-all of opportunities in this field for research. With that, I think I've timed it for about 5 minutes with questions. Joel.
Matt, so as all the residents in the room know, there's a few people we're all very familiar with by name who keep getting admitted. Some of that's due to cost of medication or modification medication, but as you point out, there are other issues. It seems to me that's an expensive group of people to the health system. What concrete things, to put your hospitalist hat on, are being done to try to reach out to those people in an ongoing way to try to help support them in all the ways they might need to be supported that would improve their outcome and also help to diminish their frequent emergency room visits?
So I think first off, in the population of people who are at Duke, who qualify for Duke Well, I think getting them involved with Duke Well is important. And that's something that you can see on a taskbar on the left side of your Epic screen. When you're seeing a patient, there's a little yellow banner that says Duke Well eligible. If they are Duke Well eligible, tag it, put in that referral, and what will happen is you will have them associated with almost a concierge service to help deal with things like getting medications, encouraging medication adherence, answering some basic medical questions and things like that. I don't have numbers on it yet. It's on the to-do list, but I've referred a number of my patients to Duke Well who have been high volume ED consumers and things like that. And I've seen a reduction overall in their utilization of the ED and more adherence. So I think there's actually a good concrete program that Duke has for that. Epilepsy is not one of the baseline disease states that focuses on, but most people with epilepsy have one of those, like mental health issues or cardiovascular health issues and things like that. So you should be able to tag them into that system. So I think that's one concrete thing for people in this area that you can do. I think the population of people who have recurrent visits to the emergency department almost universally also have some mental health issue associated with them, whether it be anxiety, depression, bipolar disorder, or a personality disorder. Insofar as it's possible to encourage it, I encourage referrals to our mental health providers. And I think while it's an imperfect solution because they have to want to do it, it's better than nothing. And on occasion they will go, and it will benefit them in the long term. Those are the two things that I think that are concrete interventions that we can do. More broadly, if I had a wish list, I whine at every drug company rep I ever bump into that they need to come up with a depot anticonvulsant. I just think about how something like the depot antipsychotics have changed the management of schizophrenia. It would be nice to just inject someone's left butt cheek with a little bit of an anticonvulsant and then see them back in a couple of months. But I don't think that's happening anytime soon. And then I think a lot of these folks have, in general, poor attachment to primary care. So if you see that, again, I can't guarantee that they'll go to those visits, but throw in a referral to primary care. Anything that gets them a little bit closer tied to the medical system is better.
So if anyone has a question on the internet, just put your name or your question. So in the audience, any questions? Jim.
So there's all these new anti-obesity
Ozempic
ones. Is there any work done to disentangle weight loss and exercise if you could get people to lose weight that have the same benefits as actually exercising?
So I have not looked directly at that literature, but I will say that there seems to be some things that happen in the brain separately from weight loss. So the body secretes insulin like growth factor and some other. And I'm blocking some of the cascade that happens with exercise. That's different than pure weight loss. So there is a neurohormonal response to exercise, that is different than just weight loss alone. So I suspect you will certainly get some benefit. Weight loss is great, reduces hypertension, reduces risk for atherosclerosis, but I think some of the mood effects and stuff like that will be less beneficial.
So Matt, can you provide more information about hopscotch? Is it hob or hop?
It's hopscotch. That's he's spelled it. So hopscotch is a structured self-management in epilepsy program. I believe it's run by the Hopscotch Foundation. It's again a structured program that deals with behavior and also it's sort of a mix of the didactic self-management education strategies that we talked about and the mood and behavior strategies. It's a little bit more to unpack than we have in the next minute or two, but I think that it's something that is a really good benefit that we have here. And I'll connect you with, well, you know Dr. Stewart, so I'll connect you with Dr. Stewart afterwards. What about app use with medical?
No, I'm going to generalize Carolyn's question. So Carolyn is asking about app use. I'll generalize that. Everyone in this room agrees exercise is great. Every patient agrees that exercise is great. But behavioral change is still in the dark ages. How can you get somebody to exercise?
So I think we need to look towards Silicon Valley for that.
Well, they thought those Fitbits would change it, and they haven't.
No, but they do change behavior. And I think we just need to figure, yeah.
Very transiently, like everything. Everyone loses weight for a week or a month, and then it's back.
Right, but I think what we can do is we can look at the things that aren't changed. Like, for example, TikTok and things like that. I think if we can figure out ways to gamify fitness, and we can look at ways to basically make fitness visually and behaviorally more addictive, then we'll see more of it. I can say that there are some things that happened in COVID that were really interesting in some of the niche exercise worlds. There were a lot of gamified virtual fitness programs that came out. Peloton thrived during COVID. For cyclists, Zwift and another game called Full Gas were really popular and made just a killing during COVID. And I think if you have a captive population with video games, it's going to make it, more likely that they're going to play the video games. And if the video games involve a bike, great.
I think you're an optimist. So
probably
the only behavioral intervention I've ever seen, and I don't even think it's behavioral, if you come into the hospital with a heart attack, you stop smoking. 50%. I mean, it's a big number. It's one of the few things. And ostracizing smokers, stick them into those plastic things outside, also had a big effect on smoking. But aside from smoking, bariatric surgery and Ozempic are going to actually cause weight loss. Dieting of any kind does not cause sustained weight loss. I think you're right. You're going to have to come up with an exercise shot. You are, because people won't do it.
Wayne.
Well, I think we all agree, exercise can have a general benefit, likely can have a huge benefit for epilepsy patients. I think you first still have to show the evidence, do a big study. I'm not as optimistic as you, because the only thing that you show is a lot of study, small studies suggest exercise good for stroke recovery. But there's no big study that demonstrates. The only big exercise-based rehabilitation program is that the cardiac rehabilitation program. Big evidence, cost effectiveness, pretty good implementation in the US, but globally, it's very, very low.
But Wayne, does it continue after the period of rehab? Do they keep doing it after the few months?
Yeah, if you have a heart attack, it's automatically linked with CMS versus a stroke. It's still CMS.
But Wayne, the question is, do the heart patients continue to do it once, or do they get that benefit forever?
I think the study will really show, I think 6 months even to 1 year really shows for your life. Yeah. So I'm pretty sure this can work, works for epilepsy patients. I think the big study. Then you can get a CMS. Otherwise, the patient not going to be able to do it.
Yeah, absolutely. I would love to see that. Unfortunately, with epilepsy, you run into the problem of funding. It's a tough world to get philanthropic support and foundation support for that. One thing to mention, Rich, with regards to why smoking cessation after cardiac arrest or heart attacks helps. There's some evidence to suggest that people who have major discrete life stressors have a period of plasticity where they can engage in some habit changes. So, you know, an MI is a pretty traumatic event, and that leads to a period of
a seizure is not.
Well, it depends on the person who has the seizure. If it's the first time seizure, that's a pretty traumatic event. But for some people, it becomes a sort of a chronic process, and that poses challenges. But I do think hospitalizations offer an opportunity for that. And there's, you know, an opportunity for behavioral change during traumatic enough events that put you in a hospital.
So agreed, but I mean, I'm just really cynical about behavioral change.
And as Dr. El-Husseini asked, is there any evidence that suggests that exercise reduces seizure frequency? As I said, there's a little bit of small study evidence. It's not something I trust, but it certainly is a tempting target to look at if you were to ever be able to get funding for it.
I guess one of the questions you could ask is, why do people who exercise? I mean, because you've got what, 10 or 20% of our patients who are like exercisers.
Oh, I think
the question is, why do they do it?
I think there are a ton of good questions to ask around that. I mean, you know, we have in our department an ultramarathon runner, right? I mean, why do some people exercise to the point where they're doing something that actively makes them miserable, but they enjoy it? I think these are legitimate questions. I mean, imagine what a potential pain management breakthrough it would be to bottle whatever, you know, suffering someone enjoys during an ultramarathon. I think that's a really cool avenue for behavioral pain research. I mean, there's just a ton of stuff to ask about it, but, you know, unless you have a plausible chemical that you can study in pharmaceutical research, no one's going to throw money on it because it's not a moneymaker. But I think it's fascinating stuff.
I mean, I think most of the people who exercise as adults were exercising as kids too. That's my 2 cents.
To some degree, but I mean, there again, I think there is that stress-related plasticity, and I think these are things that probably can be conditioned. You know, but I think it has to be a process, right? It has to be a conditioning process, and you can't do it with people who are totally averse to the idea. You need to have some openness to the idea, but it is a habit, and habit formation is a challenge.
It is a habit. So during Matt's talk, I looked up the phrase workout. So when I was young, there was no such thing as a workout. You exercised or you trained if you were on a team. But the word workout was popularized by who? You're probably too young. Jane Fonda in her 1982 video, Jane Fonda's Workout. I mean, she was a sensation with the leg warmers, and everyone was watching those. They weren't even DVDs. They were like tapes or something. I think she had a TV show. But yeah, that's where the phrase workout came in. It was introduced. It existed a little bit, but her tape was a huge thing. And then there was Jim Fixx. Remember Jim Fixx? He was this runner guy. And nobody used to run. And then in the 80s or 70s, people started running because of this guy, Jim Fixx. And that's another thing. Like, why did some people start running at that point? Before that, that was not even a thing. You didn't exercise. There was no need. Even professional athletes didn't exercise. You know, football players, baseball players. Yeah. So somehow,
he dropped dead of a heart attack.
Yep.
Jim Fixx died. He died of a heart attack in his 40s. Yeah.
Well, he also
it's a true fact.
He had an attack of the bad genes too.
Yeah, he did. Anyway, exercise is good for you. You should do it, but I don't know how to convince you. You know? Good talk. Are you going to show me that Luedke thing, baby?
Yeah.
Let's go look at my computer. I mean, I agree with you. There's nothing more important than exercise, but why